A fireside chat follows on transforming patient experience and phasing the new normal. That's me, together with Dr. Thomas Howell, Assistant Medical Director of Patient Experience of the Mayo Clinic. Thank you very much for giving us this time to interview you. Welcome again to HMA Virtual, where we have hospitals in Asia who are joining us today. So you're head of patient experience, associate head of patient experience in Mayo Clinic. Not everyone starts as a patient experience head or a guru in hospitals. I mean, you're a medical doctor as well. So share with us, how did you get into patient experience? And it's been a while that you've been in patient experience for Mayo Clinic.
Yes. So I've started several years ago, and it's a realm or a part of the practice that largely didn't have a lot of physician leadership for a long time. And I know many organizations are just starting to build their patient experience group or network. And I was actually driving back from a meeting with somebody who had been involved in it administratively and said, she said, we need a patient experience person for our local region. And I just said, well, I could probably do that. And so that's how it started. So somebody kind of asked, and I started in a more local role, and then moved up through the health system and then to the larger Mayo practice overall. It is something that I've really always believed in, that medicine is much about people's hearts as it is about their heads. And fortunately, I've been pretty successful at it, I think, with my patients, and have learned a lot of things now that I have lots of gray hair. So it's been something that it's been nice to see it grow. Originally, I think even maybe 5, 6, 7 years ago, in our organization and in the United States, patient experience was kind of two things. It was the complaint department. If people had a complaint or grievance, that's where you went. And we still do some of that. And it also was like the secret data, the patient experience data. So satisfaction surveys. In the United States, we have some government mandated surveys that we have to do. So we share data. So we largely manage complaints and share data. And it's been nice to see that evolution to a much more holistic idea and a lot more interesting work than just, making graphs and showing reports.
So how different is the patient experience practice that you do from all these administrative patient data and complaints department?
Well, I think there's a few things that have happened in the United States in particular in the history around patient experience. And when some of the data came out that said we can do much better, we can be much safer, and we can improve experience in the early 2000s, and then the government got involved with mandated surveys, people started paying attention to it. But they did so in a way that was really about improving numbers. So how do we make our metrics look better? And over the last few years, I know here at Mayo, we've really focused on how do we make the experience better, because our primary value is the needs of the patient come first. It's not the needs of the graphics or the metrics come first. So we're working hard to understand that this is about our core values and improving everybody's experience. And by everybody, it's not just the patient that's going to fill out a satisfaction survey, but it's their families, it's the caregivers. It's hard to have satisfied patients if you don't have satisfied or happy providers. And with COVID, that's been a real strain. So we've had to deal with that. So I think it's become much more about improving everybody's experience so that we can provide better care and care that feels more personal and more connected, and much less about how do we move a metric, understanding that if we provide that really great relationship with patients, our satisfaction scores are going to be fine.
Patient experience is fairly new, especially in Asia. And it's pretty much still maybe the administrative complaints, metrics, rather than real patient experience. So before we go into how it's changed with COVID, maybe talk a little bit about the 5 service lines, what these are, and just a little bit of description.
So a little bit of our structure and how we actually work day to day. So obviously we have 2 service lines that are legacy service lines that we've always done. One is service recovery. So there are still complaints and grievances, and we have mandated rules on if there's a grievance filed, if somebody says, I wasn't happy with how my care went. We have rules on how quick that has to be dealt with, what the documentation has to be. So we still have a very active group doing that. We are somewhat jokingly, but somewhat serious, starting to think of them as not the complaint department, but we want to call them the Office of Very Helpful People, because we want them to be helping do positive things as well as responding to service recovery lapses or service recovery in where we have care lapses or people that are unhappy. And it's interesting because it turns out that your most loyal patient is not somebody that has had something go right all the time. They're probably somebody that had something go right most of the time, but they had something that didn't go right. They had a service fault. And then you responded to it and fixed it. So you responded to their concern and made it right. Those people are very loyal because they feel that they're heard and you'll do something if there's a problem. So it's a very important part and something that's always been there. The other thing that's always been there is our research team. So that's the survey group. And we've branched that out now to not just be the group that administers the mandated surveys, but also starts thinking about how we can proactively get information or in the moment get information from patients. So we know if there's a problem that we can respond to it right away, or we know if there's a preference that we can respond to that right away. So that's our surveying and research group. So those are the two kind of fundamental things that I think almost everybody would have. We then have a training and education group. And training and education has been very active with COVID because we had to switch a lot of our care from in-person care to virtual care. Well, how do you do that and still make the connections and retain the connections? So they put out some 2 to 3 to 4 minute little short videos. Some are videos, some are slideshows that have music behind them to remind people that it's still about the connection. Here's things that you can do on a virtual visit to make it feel better to patients. Here's things to be mindful of not doing so you don't fall into traps that you might not think about. And they've been very active doing that. It's been very successful with our group to support the practice. So looking at ways they can support the practice with trainings. Some of those trainings are more advanced around how to use empathy, how to use motivational interviewing to get at really the heart of what patients' concerns are. And some of those courses are in-person, hour-long courses. Some of them are very short, quick snippets that are 2-3 minutes long. So that's a group that we really have just stood up over the last probably 3 years. And we have dedicated staff to that. Our improvement partners are the people that are in the hospital, in the clinics, and are working with the practice to help improve. So they're doing things like shadowing providers to help them with their communication. So little hints. One of the things I'll tell people is if you ask a patient, do you have any other problems? They'll oftentimes just say no, because they don't want to be a problem to the doctor. They feel bad they're taking up your time. But if you say, what other concerns do you have? They'll open up and they'll tell you things. Instead of asking patients, what are the list of all your aches and pains and complaints and things that you have for the reason you're in the hospital. So we call those chief complaints. If you say, what is most important to you? What do you hope we can help you with? And what are you most afraid of? They will, in actually less time than if you go through your list of questions, they'll tell you everything that you need to know. So that's a trick on how we do those things and talk to patients in ways that are more effective. So our improvement people are in the hospital doing those jobs and that work. and a lot of other improvement meetings with parts of the practice as far as department meetings, quality department meetings, again, being on the floor, helping our nurses do more effective bedside handoffs. So when shift change comes, they talk to the nurse who's coming on in front of the patient at the bedside with the patient involved in the conversation. It's much safer. It's much more engaging to the patient. Once you get good at doing it, it's more fun. So those are the kind of things that that group is involved in. And then our last group is our customer relationship management. We call them now experience relationship management because we want it to be more holistic. And they're really involved in innovation and putting all these pieces together. We have lots of data at Mayo Clinic that comes in from many sources, but all that data needs to be somewhere where somebody else can use it. So for instance, if we have a patient who used to be a professor at Mayo Clinic, we can show that on our electronic health record. But if it's not in a place that anybody can use it and we can't do anything with that information, that's a useless piece of information. Our alumni group has collected that, but nobody knows about it and nobody can use it. If we have somebody who's going to go and talk to a group in Phoenix, Arizona, or your group, and our CEO, Dr. Ferrugia, has just talked to that group, it'd be great if I knew that, right? It'd be great if I knew that I was talking with your group. So we're not stepping on each other's toes or getting in the way of each other, and we can help make that as useful as possible with all those interactions. So just some of the things they're doing. When COVID came, a lot of text messaging and finding new ways to connect with patients because everybody doesn't have a computer that allows them to use our electronic health record portal. Everybody doesn't have a phone that they ever answer. Oftentimes people don't answer their phone now. They'll look at a text, but they won't answer their phone. So what's the best way to connect with patients? Once we know that, we need to stand up the technology, but we also need to collect that information and store it so that if your preference is to connect with me by texting, I don't the next time try and call you on your landline phone because you're going to be frustrated and I'm going to be frustrated. And you already told me how you want to be contacted. So those are the five basic kind of parts of the organization and what they do day to day.
So now, come COVID, how exactly did patient experience change during COVID?
Well, I think it was very interesting because we basically shut the practice down and moved everything to virtual visits.
Okay.
We were very concerned about needing to provide a lot more service recovery. We thought patients would really struggle with that. And what indeed happened is we didn't have as many complaints as we thought we would. And patients responded well to it. So we went from almost no virtual visits in the health system to 11,000 visits and virtual visits, very quickly and inside of a week. And now we're back down to a more balanced approach where we have more inpatient visits, but we're really trying to still do virtual visits where it's important. We found that the patient satisfaction scores didn't really change very much. And I think some of that's our training and education that we got out as quickly as possible in little small snippets that were useful for people. We did notice that if you're going to do virtual visits for patients, we have to be able to provide the infrastructure and the support to the infrastructure. And when we started moving our staff back to regular visits, in-person visits, and took away some of that support, our satisfaction did go down a little bit. So that's a key learning is the technology has to work and people need help with it. If you can imagine, another thing that's very different is hospital visitation, right? How do you get people in and out of the hospital safely? What doors do they go through? How do you do screening? All of those things had to be stood up pretty quickly. It's pretty smooth now. Patients are very accepting for the most part of restrictions on visitation because we don't want more people in and out. But we realize that we have to be able to make some reasonable exceptions for patients that are pediatric patients, patients that are dying. How can you do those visits for patients that are very sick from a hospital that might be across the street, and we're trying to not move people. So a lot of technology to stand up, but always remembering that it's not about the technology. It's about the connection and the human piece, and trying to retain that as much as possible. The other thing that I will say is a learning, and I talked to a lot of people across the country, and we started thinking about this fairly early on because we were seeing it. Patients really gave us a lot of grace because they knew what we were doing was difficult, and they were grateful for the effort and the sacrifices that frontline providers, in particular in the hospital, were making.
That's right.
Our staff was very difficult and continues to be very difficult for them. We're short staffed. If someone's exposed, they have to go out for 2 weeks. So it's been really hard on our frontline staff, even our desk staff, right? They're constantly rearranging schedules and trying to screen people and do a lot more work in a small amount of time. So we need to understand that this is hard for everybody, but it's really hard for your partners and your staff that are supporting you. So everybody, give them the benefit of the doubt and try and support each other. That I think we've done well, but people are getting tired. I think the trainings helped us to have the patient experience not degrade, not be worse. But we've asked a lot of our healthcare workers for as far as long hours, working short staff, doing things that are, you can't just go in and out of a room, right? You have to put all your protective gear on. You have to do things that you didn't used to have to do. And we're already working hard. Now we're working harder in a way that's less efficient with fewer people.
Right.
And there's been a lot of financial strains with organizations, so they feel that too. So my biggest concern about this, I think we're going to, it's a very difficult thing, and it's been, a serious pandemic with a lot of morbidity and loss of life, which is tragic and difficult. Right now, I think we're doing okay, but where we're going to run into trouble is burning out our providers and our staff. And there's some new data on physician burnout that says this is really a difficult time, and it's been aggravating that. So I think the learning for organizations is to pay attention to your patients, but don't forget about your staff and support them in every way possible because they really need it.
And you mentioned about, I guess, when you say virtual visits, you're really referring to telehealth, telemedicine, correct?
Say about that is one of the good things, the blessings of this has been that we probably did 5 years of work in about 2 weeks.
That's right.
To stand up telehealth and virtual visits. And for a lot of visits, telehealth is really useful. So I was just meeting with the head of the GYN oncology department this afternoon. And he said, we used to send our doctors out to some different sites in the community practice. That really doesn't make a lot of sense because virtual visits are great for doing these consultations. And we've set up a system that allows us to do that. Patients accept it. If we can get the background information from our very capable providers in the health system, we don't need to be spending 2 hours driving back and forth. We can do a lot more good in a shorter period of time. And patients don't need to necessarily come to see us until they need their surgery. So we've learned a lot of things that are going to make care more convenient, more streamlined, because we were forced to do that.
So there are some good things that's coming out of COVID, just making us more efficient. That's correct. And I think even for Asia, where there's lack of access to experts in remote towns and provinces. So we've also discovered that telehealth has sort of addressed those issues with regard to lack of access. And what about the use of device diagnostics? Because one of the things that we talked about here in Asia is it's great we're using telehealth, but it's more so for consultation, not really for diagnosis. Do you have the same experience in the US, in Mayo Clinic?
Well, I think the other thing that has happened is, and this was coming pretty rapidly anyway, but the other thing that's happened is those technologies to be able to do advanced diagnostics in your house have really accelerated. So, you can get a pretty good EKG off of your phone now. We're in obstetrics, we used to have people come to the office and we would weigh them and do their blood pressure, listen to the baby and answer questions and provide some guidance to them. If you think about that, if we send you home with a device to listen to the baby, which is relatively inexpensive, it costs somewhere between probably 35 and 50 American dollars, and that lasts for forever, as long as you change the batteries.
Yes.
And a blood pressure cuff, most people have a scale. I can do several of those visits with you from your place of work or your home. You don't need to stop your day and come into the office. And we don't need to bring you into the office and expose people to possible COVID in that way. So even simple things like that have been accelerated and been able to do that. And it's been a big satisfier. Most of our patients really appreciate that. But the technology is coming really fast. I think that we'll be able to do a lot of diagnostic work, a stethoscope that the patient can use to move around. One of my family members is a sports medicine doctor, and he said, I can do a virtual sports medicine exam with a first patient and get 90% of the information that I would previously get in person. I can't do procedures, but I can do a lot of diagnostic work and get things started without having to physically be in the same room as a patient. And that's really an advantage, especially like you mentioned, for rural areas or places that don't have that access,
Right.
but I can teleport in by telemedicine, right? And provide some of that access.
Right. Pandemics, emergencies, they're always going to be a part of our lives. We realize that now. Like COVID is not the end, right? We realize these things could happen, and so we need to be prepared. So how do we ensure that we don't lose sight of the patient when all these happens? Is there a process to guard us against failing the patient?
Yeah, I was very concerned about that. And I think it comes down to a few things that we've talked about. One is that you have to do things based on your values. And you can't just be reactive all the time. So whatever your response is we in patient experience always say, how does this support our primary value, the needs of the patient come first? And as long as you do that, your staff will get on board and they'll work very hard to make that happen. I oftentimes will say nobody cares about hospital patient experience because the government's going to give them an extra so much amount of money because they did better on their surveys. Right? There's no frontline nurse that says, I'm going to work hard so we can get a better score on our surveys. But there are nurses that say, I'm going to work hard so the experience of the patient and my experience providing care can be better. One of the other things that we talk about is your experience at providing care, your day-to-day work is better when your patient's experience is better, because that's one of the reasons you're in healthcare in the first place. So, connecting back to why we're doing this has been very helpful. So we've been trying to start conversations with why are we doing this, not what are we going to do and how are we going to measure it. So I think that's one of the ways you don't lose that. And then simple tools like requiring people to think about whatever we're going to do, how is this going to affect experience? When we went to essentially shutting down elective procedures and virtual care, patient experience was at that table and talking about how whatever decision we're going to make is going to affect experience and how we're going to respond to that and try and do as good a job as we can to protect that patient experience and the relationship. So I think those are things, the experience really did much better than I anticipated it would. But I think some of that's because we thought about those things in the moment.
Any encouragement to the frontline managers and executives here in Asia?
Yeah, I think it's all of experience is about your values. And then the other thing is the values and priorities of the patients and your staff. So, when you have those conversations about how to improve things, don't start with, I saw you do these things and you should change them, or we have a mandate that you need to do these things. Start with, as a nurse providing care in the hospital, what do you most care about? What 3 things do you want patients to say about the care you're providing if you're talking to a physician? And in those conversations, you're listening to them, you'll understand their priorities, and they're going to be in some respect, the same things as the organization's priorities. Leverage those conversations. I think that's the secret, is finding values that are coincident with the organization's values, but people really care about, and then getting them excited about how what we're going to do together is going to really foster their experience as well as the patient's experience being better.
Great. Thank you very much, Dr. Howell.
Yeah, my pleasure. Have a good day. Good evening.
Thank you.
Good evening, Dr. Howell. It's me and you again. How are you?
I'm okay, Pinky. How are you?
I'm good. So, is it all right? I know we just found out that you just
It's
got.
fine.
Okay. So, yeah. So, just so everybody knows, I mean, Dr. Howell really took an effort to join us tonight, his night. He just got diagnosed with COVID today. So, prayers go out to you, Dr. Howell. But thanks very much for joining us. So,
Thank you.
actually,
So I'm in my my room.
right.
My
so
room
you're
that I'm allowed to be
quarantined.
in. So
Right.
coming to you from quarantine.
Correct. We really just have a short time, so we have time for just one question. One thing that was asked yesterday was, okay, you talked about teleconsultation and how you were able to manage patient experience even with teleconsultation. How do you measure patient satisfaction through those things and other things that you did during COVID, whether teleconsultation or the use of PPE, facing the patient, and all those new methods during COVID?
So we did a couple of things. Most surveys go out to the patient after they have had their episode of care, and our government mandates a way that has to be done. We added some specific questions around telemedicine. So ask about how was a video and how was the phone visit if it's a phone visit. And we actually have that data split by type of visit now.
Okay.
And found that video visits are almost identical to in-person visits. Phone visits a little bit less satisfactory, but they're pretty close. There's, the number of people that give you a top score is 2 or 3% different. It's not very different. So we actually augmented our previous surveys with direct questions. The other thing that we did was we're rolling out point of care surveys. So asking patients in the moment, and soon we'll have questionnaires that are much less questionnaires than they are, do you have a concern? Are we doing this right? As we've tried to encourage nurses and doctors, it's so important now that they be on the same page and that the team be looking like it's functioning as a team. Even when we have to do virtual care, that we want them to interact with the patient at the same time. And then we're asking, did your doctor and nurse interact with you at the same time, and did they both contribute? So we're asking those questions directly in real time, and getting those answers. And our staff have really stepped up. We're doing quite well on those direct questions.
Great. Dr. Howell, thank you very much. We'll send you other questions that may come up because the video is live all throughout the year, but we'll send them to you via email. But do take care. Get well. Thank you, Dr. Howell.
Thank you. Appreciate it.
Thank
Appreciate
you.
the opportunity. Hello,
All
everybody.
right.
Goodbye.